Hi everyone. I was told I have to use a microphone, so I'm going to use it here since they're recording. But it's great to see so many people here on the last day at this time with a lot of other things going on, so thank you for coming. I'm Steve Cico. I am a pediatric emergency medicine physician at Indiana University. I'm the fellowship director of the PEM program there, and I'm one of the assistant deans with GME and faculty development. And I'm going to let the rest of my team introduce themselves, and then we'll get started.
Hi, I'm Meg Wolff. I'm the Med Ed Fellowship Director at University of Michigan.
I'm Sarah Tomlinson. I'm the Assistant Program Director of the Pediatric Emergency Medicine Fellowship at University of Michigan.
Following that theme, I'm Michele Carney, Pediatric Emergency Medicine faculty at the University of Michigan, also the Pediatric Emergency Medicine Fellowship Director.
Good. So the way we thought we would do this, and this is the first time we've done this here, so we'll welcome feedback at the end, is that we have come up with 8 articles and one little bonus that we're going to show you. And we've divided them up into 4 main categories. So what we thought we would do is go through which articles we picked, the background about the article and why we chose it, talk about the methods and the results that are important, and then most importantly, how we think this should change the practice of emergency medicine for kids. We're going to go through each of the articles kind of in their group, and then we'll try to save all the questions for the end because I know a lot of people are leaving to catch planes and things like that. So we'll leave the discussion for the end. That way everyone who does have to leave early will be able to at least hear which articles we picked. If anyone would like copies of either the articles or the references, just leave a business card here on the front table and we'll make sure that we get them to you, or write down your email on a piece of paper. All right, so we're going to get started.
So the first category of articles that we decided to talk about was febrile neonates. This is a population of patients that I think anyone either general EM trained or pediatric EM trained is really interested to know kind of what the best management is of these small children. The first article that we chose to review is titled Risk of Bacterial Co-Infections in Febrile Infants 60 days and old and younger with documented viral infections. So approximately 500,000 infants less than 60 days old are evaluated in the emergency department for fevers, and depending on who you're talking to, about 8 to 13% of those children have confirmed bacterial infections. And there have been articles that have just shown that the risk of serious bacterial infection, or SBI, is lower in patients with confirmed viral infection. And SBI is defined as UTI, bacteremia, or bacterial meningitis. So this article sought to also see what the risk of SBI was in patients who tested positive for a specific virus versus in patients who had viral negative testing. This was a prospective observational multi-center study. It was a convenience sample of a larger data set used in a parent study. And this was through the PEM initiative, so it was across 26 sites. The inclusion criteria for this study was having a documented rectal temperature of greater than or equal to 38 degrees, either in the emergency department, within 24 hours at home, or from another healthcare facility. The child had to be less than 60 days of age, and they had to have been undergoing a workup for an SBI in addition to having some sort of workup for a viral infection. So whether that was a single influenza test, a respiratory, like a RSV test, or a full comprehensive respiratory viral panel. Excluded patients were those that were critically ill or obviously septic, premature infants less than 36 weeks gestation, anyone with pre-existing conditions, comorbidities, or indwelling medical devices. The main outcome of the study was the diagnosis of SBI, and like I said, that was defined as bacteremia, bacterial meningitis, or UTI, and they had specific guidelines as to what qualified as a UTI diagnosis, either by suprapubic aspiration, by clean catch specimen, or by catheterized specimen, and these were in line with the AAP guidelines for UTI diagnosis. Secondary outcome was they checked which infants tested positive for viruses versus which infants tested negative, and then they compared the risk of SBI in patients who were viral positive versus viral negative, and then they also sorted those out by age as well, less than 28 days, more than 28 days. And then finally they compared the rates of SBI by individual type of virus isolated. They had a total of 2,945 infants, and overall 9% of them had SBI, which fits with what other sources are saying is the incidence rate of SBI in this group. So they had relatively evenly matched groups in terms of virus positive testing and virus negative testing, and the incidence of SBI in the virus positive group of infants was 4%, and in the virus negative group was 13%. And then they noted that the rate, when they looked at each SBI individually, they looked at UTI between virus positive and negative, bacteremia between virus positive and negative, and then bacterial meningitis. All of those were significantly lower in the viral positive group compared to the viral negative group. However, the difference in meningitis just wasn't statistically significant, but it was absolutely lower. Additionally, they looked at that age group stratification like they talked about. In the less than 28-day range, the rate of SBI was higher at 12%, and greater than 28 days, it was 7%. And then they took the virus positive and negative by age range, and they said that virus positive infants less than 28 days had lower rates of SBI than virus negative infants of less than 28 days. When they did a sub-analysis to see if in the setting of a specific virus was the rate of SBI any different, they found again that the rates of SBI were lower in the virus positive group regardless of any specific virus. So how does this change our practice? Well, infants with confirmed viral infections are at a lower risk of SBI than infants who tested virus negative. I think this is important as we are having more point of care testing available in terms of testing for viruses. It becomes more part of our emergency department medical decision making. However, there still was a 3.7% of SBI, incidence of SBI in patients who had confirmed viral infections. And within that percentage, 1% was considered an invasive infection, such as bacteremia or bacterial meningitis. So I'm not sure that that percentage is actually low enough for me to change my practice to do a full septic evaluation in these infants, particularly in that less than 28-day range, because those infants had higher rates of SBI and they had a higher rate of the more invasive ones. So particularly in an infant less than 28 days, even in the setting of a positive virus, I think I probably still would be doing a full septic evaluation in that patient population. Okay, so the second article is identifying a clinical prediction rule to identify febrile infants 60 days and younger at low risk for serious bacterial infection. So these are done by similar studies, so the background is kind of similar as well. We see again that general rate of 8 to 13% of febrile infants that are diagnosed with a serious bacterial infection who present under 60 days of age. SBIs have serious complications for the patients, and they also are associated with very high healthcare costs in terms of workup, and then all of these patients being hospitalized while they're waiting for culture results to come back. This was used in the same data set, so some of the methodology is the same as the first article. It's prospective observational. They use this convenience sample again from a larger parent study. The inclusion criteria was about the same. You had to have a fever, you had to be less than 60 days, and excluded were if you were critically ill or clinically septic, or if you had any comorbidities. Also, if you had received antibiotics within 48 hours of evaluation, you were excluded from this study. So what the researchers sought to do in this article was to collect any predictor variables that they thought might make a difference in the diagnosis of a serious bacterial infection. They included age, temperature, duration of your fever, the Yale observation score that they solicited from the clinician. They also solicited the clinician's suspicion for SBI by saying, how suspicious are you? Less than 1%, 1 to 5%, 5 to 10%. 10 to 50% or greater than 50% that the patient had a serious bacterial infection. They also looked at the urinalysis, and specifically they decided you were either positive or negative if you had the presence of nitrites or if you had the presence of a specific amount of white blood cells on the microscopy. The WBC count, the ANC count, and the procalcitonin level. Then using recursive partitioning analysis, they derived a prediction rule. And then they took a second group of patients within their cohort and they validated it. So they had a derivation group and they had a validation group. So in this analysis, they had 1,821 infants. They isolated 3 variables for use in their rule, and that was a negative urinalysis, an ANC less than or equal to 4,000, and a procalcitonin less than or equal to 0.5. They actually started with slightly different numbers for those last 2 variables, but then they rounded them to a more user-friendly number, essentially, and they got the exact same analysis. They went with these numbers. So in the derivation group, the rule identified a group of 522 patients that were considered low risk for SBI. And then within that group, only 1 patient was positive for SBI, and I think it was a patient with bacteremia, and the overall SBI risk was 0.2%. The interesting thing about that 1 patient is that the initial blood culture was positive for Enterobacter cloacae, and then they did another blood culture before initiation of antibiotics, and that culture was actually negative. So the patient was still treated for bacteremia, but there was a question about the diagnosis since only 1 culture returned positive. In the validation group, the rule identified a group of 497 patients at low risk for SBI, of which only 2 patients were positive for SBI, and 1 of those was a patient with the UTI, and 1 was a patient with bacteremia. So the overall SBI risk in the validation group was 0.4%. So how does this article change our practice? I think that it may lead to increased use of procalcitonin for risk stratification of SBI in young febrile infants if it's not already part of your workup in the young febrile infant. I think because those 3 variables, none of them had anything to do with the CSF lab or with the culture, there's a potential to decrease the rate of lumbar punctures. And then also using this rule may help to decrease the rate of empiric antibiotic use as well as hospitalizations. Lastly, I think everyone still exercises a lot of caution in a less than 28-day population because their rates of SBI are higher.
So we'll move on to our favorite respiratory illness, bronchiolitis. So this article, Predicting Escalated Care in Infants with Bronchiolitis, is through the PERN network. The PERN network, in case you're not familiar, is 6 collaborating networks worldwide. And so PCARN is one of them, PEM-CRC, those are things that you probably have heard of before. So bronchiolitis is a major healthcare and financial burden, 16% of all hospitalizations in the first year of life. In the ED, it would be helpful to know who would worsen and who we can confidently send home and not worry about them. This particular study is ED focused, and it shows the predictors of escalated care in bronchiolitis. So escalated care is defined as hospitalization plus airway management. Airway management can be high flow, CPAP, intubation, or just simply going to the intensive care unit without any airway manipulation. So the primary objective was to identify clinical predictors of hospitalization with airway support among infants evaluated in the EDs around the globe. primary outcome measure was escalated care during inpatient or ED stay, which is high flow, non-invasive ventilation, intubation, or transfer to the PICU. And secondary outcome is actually looking at this tool and see the diagnostic accuracy of this clinical risk score. So it's a multinational retrospective cohort study. They had this information from a different study and then reevaluated the data and looked at different parts of it. It's conducted at 38 pediatric EDs associated with PERN. The children were less than 12 months of age, and this was diagnosed between December and January of 2013. The discharge diagnosis of acute bronchiolitis, and it was a random sample. They used a random sample generator to show which ones they were going to look at. So 2,722 had complete data, 261 needed escalation of care, 164 being high flow, and 70% of those went to the floor, 47% non-invasive ventilation, and 12 intubated patients on ventilators. And then 38 went to the PICU without any airway support. Here's they selected these predictor variables: age greater than 2 months or less than 2 months, poor feeding, oxygen saturations greater or less than 90 or less than 90, apnea, yes or no, nasal flaring and grunting, yes or no, dehydration, yes or no, and retractions, yes or no. So this tool goes from 0 to 14. 0 would have none of those characters, and 14, all of them. So how does this change our practice? So going through these, if you have a patient that's greater than 2 months of age with oxygen sats greater than 90%, without nasal flaring, grunting, retractions, or dehydration, will have a low probability of escalation of care. So honestly, that's sort of clinically intuitive, right? Like that doesn't, but at least like someone looked at it and it's generalizable. It was through 38 different hospitals around the globe. So it just sort of strengthens what we believe. And it's helpful to community EDs because they have a higher rate of bronchiolitis hospitalizations. So future endeavors, it would be nice to see something for babies greater than 12 months old, and then to test this standard assessment scale. So this wasn't tested, it was validated internally, but it's not externally validated, and so that would be an interesting study to see. So our next one is high flow nasal cannula therapy for bronchiolitis across the emergency department and acute care floors. So obviously bronchiolitis is a very common illness, as we all have seen this past winter. It's $1.7 billion annually in hospital charges, so a huge financial burden to the hospitals we work at. And the treatment, of course, is varied, and there's little evidence for anything that's effective. There's strong evidence what not to use, but there's very little evidence as to what is good to use. And must have community hospital involvement. So this study actually takes into account community hospitals because it's a review of the literature, and it shows why this is, we'll talk about it at the end, but it shows why this is really helpful for community hospitals. So it's review of the review of the literature from 2004 to 2018, and then it also reviews 7 institutional protocols for high flow nasal cannula on pediatric inpatient floors. So, so you can use high flow on inpatient floors as with the results of this this review. Higher failure rates, of course, are kids with cardiac comorbidities or prior intubations. One study showed if there was no improvement in heart rate and respiratory rate within an hour of high flow nasal cannula, you might require PICU, not just in bronchiolitis, but other respiratory illnesses. And I was thinking about this fact a little bit. I mean, sometimes it takes them an hour to get used to the high flow. In general, I think that that's a true statement, but in some kids, I think it takes just a little bit longer. But when you do see a drop in heart rate and their pulse ox is good and their respiratory rate improves, those are kids that you can confidently say you're using the right modality. Another study with a PCO2 of greater than 50 initially, they had a higher rate of intubation. And because there's no standard to wean high flow, it's really hard to get them off of it. So we in the ED don't really know this, but the inpatient floors have a hard time weaning because there's really no assessment score to say this is what you do and this is how you get them off the high flow. So we know that the use of high flow nasal cannula decreases intubation rates because the humidification thins secretions. It washes out the CO2 in their dead space, and it increases alveolar recruitment. And it's generally more tolerable than nasal CPAP. Children can be kept at community hospitals, and they don't have to be transferred to the PICU. So this, I think, is really important because many kids present with bronchiolitis to community hospitals, and those kids would either have to be transferred to a children's hospital or a place with a PICU, or you can keep them on the floor and watch them and watch how they do and improve over a period of time. This would save a lot of costs to keep them where they are and not have to transfer them. So future endeavors need to utilize a standard score regimen for escalation and de-escalation of care on the floor. And this would help. It would help community hospitals, it would help children's hospitals really know how to wean these kids and get them off of high flow a little bit faster.
Great. So our next category is going to be fluid management in the pediatric population. So the first study that I'm going to talk about is a study from New England Journal, clinical trials of fluid infusion rates for pediatric DKA. So I think that this study is also an important study because it was done by the PCARN network. And for those who aren't familiar with PCARN, it's a collaborative group of children's hospitals who work together to increase numbers in pediatric research. So background, why we care. Cerebral edema and DKA leads to increased morbidity and mortality, and the role of fluids is unclear. The lore in pediatrics has always been that you have to be very gentle and very slow with fluids, different than in adults because of the increased risk of cerebral edema. And so this was a multi-center, randomized controlled study that was done as a 2x2 design, and I'll go into that on the next slide. But they looked at both normal saline and half normal saline, and they looked at rapid and slow infusion. And again, I'll explain that a little bit more in the next slide. Their primary outcome was a decline in mental status on 2 consecutive GCS calculations, and they used 14 as the cutoff, so anything that was below 14 was considered a decline. And then secondary outcomes you can see listed there below. So the way they did this study is they divided patients up into these 4 categories. And what they started with was all patients received a 10 cc per kilogram bolus of normal saline. And even that has been controversial, whether you give any kind of boluses or you just start with fluids. So 10 cc, it was a small bolus, but they did start with that. In the fast administration group, they gave a second bolus of normal saline and assumed a 10% rate or 10% dehydration based on the body weight in terms of fluid replacement over the next 24 hours. So they did a 24-hour fluid replacement, and that fluid deficit replacement was with either half normal or normal saline. In the slow administration group, they got a 10 cc per kilo bolus, but they did not get a second bolus. There they assumed a 5% deficit, and they replaced that deficit over 48 hours instead of 24 hours. So less fluids, slower replacement. And again, they used half normal and normal saline as the two arms. Yeah. So they didn't specify the time period. Typically in pediatrics, they'll do it over either 30 or 60 minutes, but they didn't specify. So what they found here, and what this graph shows, is that they did have a number of patients who had a decline in mental status, which is, let's see if I can point to it, in this line here. But what they showed was that there was no difference in decline in mental status in any of these groups. So the amount of fluid, the rate of fluid infusion, the type of fluid didn't affect what they saw in their outcomes. So it was interesting that there was no significant difference in neurologic outcomes. However, again, it's important to notice that these patients received 10 cc per kilo boluses, so they were rather small boluses. Even the fast group received only 20 cc's per kilo. And so it's not a huge amount of fluid that they got as a bolus, but it seems to be safe to bolus these patients. And then also in terms of fluid replacement, it didn't seem to matter if you use normal saline or half normal saline. So how does this change our practice? Immediate resuscitation is always a resuscitation, right? So you bolus when you need to, but when you have the DKA child who looks well and you don't have to, necessarily give them a bolus because of their immediate status, you can feel confident giving a 10 cc kilo bolus or even a repeat one in those kids. And again, this is different. When I was a fellow, the lore was you never bolus pediatric DKA. All of the arms were relatively cautious in terms of the amount of fluid and the speed of the fluid. And we're talking replacement over 24 or 48 hours, so it wasn't a fast fluid replacement. But it didn't really matter. So again, we can feel a little bit better with our DKA kids that we aren't going to harm them with the fluids that we're giving. The second article that had to do with fluids is the association between fluid balance and outcomes in critically ill children. This was a systemic review and meta-analysis. So obviously fluid resuscitation is important in pediatric resuscitations, just like it is in adult resuscitations. It can be life-saving, but the fluids that we're giving are cumulative. This has a little bit more of an impact in the pediatric population because you're talking about a smaller overall volume that you're going to be using. And so this was a review and meta-analysis that looked at 44 studies and over 7,500 patients. They followed the Cochrane guidelines for this systemic review and meta-analysis, with the primary outcome being all-cause mortality. Secondary outcomes they looked at included respiratory outcomes, fluid overload, pulmonary edema, acute kidney injury, PICU length of stay, and then they looked at some other things as well. What they found was that greater fluid overload, which was defined differently in different studies, and so it's important to talk about what is described as fluid overload. Some of the studies looked at 5% over what maintenance would be. Some looked at 10%, some looked at 15%, and some looked at 20%. So it varied based on the study. And then the time frame that was looked at in studies also varied. So some studies defined fluid overload as being fluid received in the first 24 hours. Others looked at the entire hospital stay. So again, there's variation, but increased fluid overload, however it was defined, was associated with increased mortality, increased acute kidney injury, prolonged mechanical ventilation in patients who are ventilated, and increased PICU length of stay. So the other thing that I think was really important and something that I see dealing with kids all the time is that fluid overload was relatively common in the pediatric population. And again, no study that was looked at had used any kind of objective measure to define fluid overload. So POCUS wasn't used or bioimpedance wasn't used. So how this changes our practice, I think the important things is that we have to consider fluid-sparing strategies after the immediate early resuscitation of a patient. And it really highlights the importance of keeping accurate records about the fluids that are being given. And I don't know about you guys, but I think it's pretty common for us to get patients who are transferred in with a bag of a liter of normal saline being hung, not on a pump, kind of wide open by EMS. And, I have seen kids who are, itty-bitty kids who have gotten, 700 cc's pretty quickly during a transport. So I think really stressing the importance of keeping accurate records about the amount of fluid that's being given, taking into account in the youngest kids the volume of flushes that are being given is all really important. The final bonus fluid isn't actually an article, but it was a clinical practice guideline about maintenance fluids that some of you may or may not have seen that we wanted to include here just as an FYI. This was an American Academy of Pediatrics consensus guideline from the Subcommittee on Fluid and Electrolyte Therapy from the AAP. And the key action statement is that the composition of maintenance IV fluids, the recommendation has changed for pediatrics. The AAP now recommends that from 28 days until 18 years of age, maintenance fluids should be isotonic as opposed to half normal or quarter normal saline. And you see a lot of kids, even as old as 5 or 6, who are put on quarter normal saline by outside hospitals that send kids in, or by primary pediatricians or family medicine docs who send them in. And so that's a bit of a change here, that you should be using isotonic saline. The evidence quality for this was rated as an A, and the recommendation strength is strong. And like you guys probably know, a level A is based on well-designed studies that were conducted that actually met gold standards, and they were applicable to the patient populations. The harms, or the things that I had always been taught that were not found, were a risk of hypernatremia and hyperchloremic metabolic acidosis. Those were the things that in my training I was always told, if you keep kids on normal saline too long, this will happen. And they didn't find this in their review of all the literature. So we wanted to include that just to make sure everyone knows that normal saline plus or minus potassium, depending on need, and plus or minus dextrose is what maintenance fluids in pediatrics should be at this time. So with that, I'll hand over to Meg.
Okay, guys, we're in the home stretch. So our first article is the additive value of pelvic examinations to history in predicting sexually transmitted infections for young female patients with suspected cervicitis or PID. Essentially, do we need to do pelvic exams? All of you guys know that we obviously want to diagnose sexually transmitted infections, both for public health purposes, but also for the patient, for the acute and chronic complications. Selfishly, I was interested in this study because in our department, if we have somebody on the board who probably needs a pelvic exam, they sit there forever. And so I was interested in this study. And so they looked at what exactly does a pelvic exam add to clinical judgment. So they took all girls in their pediatric emergency department who were aged 14 to 20 who were presenting with lower abdominal pain or with vaginal symptoms like discharge or pruritus, and they had all of them do urine testing for sexually transmitted infections. They then had them do a standardized history that included things like, do you have abdominal pain, do you have pelvic pain, do you always use condoms, and it was the standardized history that they took for all the patients. They then asked the providers, on a scale of 1 to 100, how likely do you think this person is to have either PID or cervicitis? And they defined that if you were 50 or greater, they were planning on treating them. So they were planning on giving them empiric treatment for a sexually transmitted infection. All of these girls then had a pelvic exam, including a speculum exam and a bimanual, and then they had the providers again say on this 1 to 100 scale, how likely do you think this person is that they have PID or cervicitis? After the patients were discharged, all of the testing for the sexually transmitted infections returned. So that stuff didn't return in the emergency department. So they were basing their treatment decisions in the emergency department based on these two things. They found that on these two things, 75% of the time there was no change in management. So after they did the pelvic exam, 75% of the time it didn't change management. Interestingly, 25% of the time when it did, half of the time they were wrong. So, so in those people who said, okay, I think it's PID, and then they did the exam, they're like, oh no, I don't see anything of it. Half the time they were wrong, and their testing actually came back positive. They looked at the sensitivity and specificity of these things, and you can see they're like really not good. So the sensitivity of history in a pelvic was 50%, but history alone was 50%. The specificity is similarly very bad. So based on this, the authors concluded there was no utility in doing a pelvic exam. After this, there has been a lot of debate about this. There was a letter to the editor that said, this is all well and good, but the CDC guidelines say that you need to do a bimanual exam to see if there's any uterine tenderness or adnexal tenderness. There's also, any of you who are any kind of FOMED outlet, there has been a lot of discussion about this article on there. I basically have taken this paper to say that it's okay not to do a speculum exam. That's not really going to add anything to your treatment, because it doesn't matter if you see mucopurulent discharge coming out of the cervix or not. But it is really important still to do a bimanual exam and do visual inspection, because we have all had patients who have told us that they have no lesions, and then you look and there's a lot of herpes lesions. So it's still important to look, it's still important to do bimanual, but you may not need to do a speculum exam in all of your patients presenting with straightforward lower abdominal pain. And then our last article is the association of preprocedural fasting with outcomes of emergency department sedation in children. So this was done, the Sedation Safety Study Group of the Pediatric Emergency Research in Canada did this study. And they were basically looking at does the duration of preprocedural fasting in kids presenting who need procedural sedation for a painful procedure, does the amount of time that they have fasted affect their the risk of adverse outcomes? So this was in 6 Canadian pediatric emergency departments, and they looked at all kids 0 to 18 who needed procedural sedation for a painful procedure. They then they defined their outcomes as pulmonary aspiration, any adverse event, and these could be pretty minor things, any vomiting or any serious adverse event. So these were things like, if they didn't intervene on, could potentially lead to serious morbidity or death. So things like significant desaturation, obvious pulmonary aspirations, they actually like saw it go in, things like that, and of course death. They then stratified this by the anesthesia guidelines for what counts as NPO status. And so just to remind you guys, so their criteria is 2 hours is clears, 4 hours is breast milk, which is interesting because I always thought 2 hours was breast milk, but apparently the anesthesia guidelines actually are 4 hours breast milk, 6 hours for light meal, and 8 hours for your, McDonald's. So they found that there was actually no differences in adverse events by duration of fasting. And they looked at this both as a continuous variable and a dichotomous variable, and so they did not see any, it wasn't like once you get 4 hours, there's this magical thing if it's less. Really there was no differences. So thankfully, this doesn't really change my practice at all, and probably doesn't change many of your practices. I would just say now we have evidence to support not waiting the 8 hours to do our procedural sedation and somebody coming to the emergency department. So those are all of our articles. We would love to answer any questions you guys have now about any of these.
That was great, thank you. Very high yield. I have a lot of questions, but I'll just start with one. And it's about the DKA literature. And I know this wasn't the intent of the study, but related to cerebral edema, can you speak to how much was found in general? Or across all the groups, it sounds like the mental status changes were the same, but does that mean kids were having significant cerebral edema, or was it just kind of minor changes in mental status?
So cerebral edema was much less. It was, it was less than 1%. I can't remember the exact number, but overall it was less than 1%. The kids with mental status change, I think it was 46 or 48. I'd have to look at the numbers to add them up real quick, but it was roughly that. But that was out of that larger number of 7,500. So it was also a very low percent who had it. 46 kids, yes, sorry, 46 kids out of that larger number. So it was a very small number who had mental status changes as well. And then cerebral edema was much, much less. Sorry, microphone here, but we were given our orders.
Just curious, could you clarify on the pelvic exam study? Just curious, did you say physicians were more likely to overdiagnose and overtreat, or undertreat? Yeah.
They made mistakes in both directions. Oh, really? Yeah. So of those 25%, half of them that they changed or they made the wrong diagnosis. It was pretty equal in terms of like over or under diagnosing. And there weren't any changes. They also stratified like by attending, by resident, and by like advanced care practitioner. And there really weren't any differences in terms of their accuracy of diagnosis.
And was there enough information to tell like were they misinterpreting discharge or?
They didn't include that level of detail. They did say so for their pelvic exams. They had to document tenderness, abdominal tenderness, adnexal tenderness, uterine tenderness, discharge, but it didn't say like cervical discharge or like just vaginal discharge. They didn't differentiate, and they didn't have to characterize it at all.
And can you clarify at what age or age you typically start? Like they're adolescent, you know they haven't been sexually active, you go.
I never believe them when they tell me they're not sexually active. I also never believe them when they tell me they use condoms 100% of the time. So I will, I will start doing a bimanual exam in somebody who does look like they have been through puberty and who's presenting with concerning symptoms. But I don't do a speculum exam.
So what was the gold standard in that study for a positive diagnosis? It was just a positive GC or chlamydia, but that doesn't define PID versus cervicitis. So they didn't really look at that. And I mean, I know this has been discussed ad nauseum, and, but I just, I think that the speculum exam maybe doesn't add that much, but how you obtained the sample, were they doing self-swabs? There were a lot of variables here that was not addressed.
Those are all really good questions. So, and you're exactly right. And by definition, to diagnose PID, you do have to see if there's adnexal or uterine tenderness. They were using urine studies as the gold standard that have really good sensitivity and specificity. So they didn't do self-swabs or anything like that. So that the tests themselves can be trusted in terms of the actual diagnosis of do they have a sexually transmitted infection or not. But no, they can't say like, did they treat it correctly, PID versus cervicitis, because, yeah. Other questions?
So related to the sedation article, our practice is no strict, NPO times. I'm curious what others are doing if they're waiting an hour or two if they did happen to have a meal. But I also wonder about the medication choices. So is there some thought related to medications that could be higher risk for deeper sedations like propofol, etomidate versus something like ketamine?
The majority of kids in that study used ketamine, but they did look at all sorts of, including propofol and using ketamine and propofol. They didn't see significant differences in the risk of this stuff by medication use. We typically will use 4 hours. I don't know what other people are doing in terms of their criteria. No. Yeah, which is our institution says 6 hours, but we generally use 4 or like 3-ish. Yeah, exactly.
But it's sort of academically disingenuous because what's 4 hours?
Yeah. No, it is. And I can tell you at my institution in the emergency department, I mean, anesthesia has its guidelines, and I think they followed their own even for procedural sedation. So the 8642, we don't use any. most kids are at least an hour to 2 hours by the time you get everything done. So, and in terms of like vomiting, the thing that we watch rather closely is whether people have gotten a narcotic, because narcotics plus ketamine increase the risk of vomiting, especially in older kids. So those kids will usually pre-treat with Zofran. However, yeah, we don't use any kind of guideline. It's up to the attending, and I would say all except a couple of our older attendings will use just whenever we're ready. We've got our team. We're going to go for it. So. Yeah, so we can send that to you if you'd like.
Okay, yeah.
If you leave your name or card, we've got a paper up here. We'll send it to you guys. Great. Yeah, go ahead.
The febrile infant literature about procalcitonin, we're thinking, we're trying to incorporate that into our algorithms for less than 60 days. Under 28 days, we're still doing everything. But I guess my concern is, so what if you get your, I think the white count's not perfect, but let's say your A and C looks okay, your white count looks okay, the kid looks beautiful. Now you get procalcitonin that's slightly elevated, now suddenly I'm capping that kid? Or how do you guys deal with it?
Yeah, so great point. I think personally, I have that same problem with procalcitonin and how we use it. We at our institution now have like a pathway based off of these guidelines where typically in the greater than 28-day range, we're not tapping even if the procalcitonin is high. If everything else looks okay, we just admit for observation and to follow the cultures. And then if anything changes during that course, then the child proceeds to getting an LP. In the under 28-day range, we're still doing LPs on all of those children. The decision is whether or not we initiate antibiotics if any of the testing is abnormal. So that's how we're using it in our institution. And if you want, I can provide you with our pathways too if you're interested, so you can have them as reference.
Do you adjust that for unimmunized?
No, because in under 60 days, it doesn't make. Oh, well, under 60 days, it doesn't make much of a difference because they're not getting their immunizations till 2 months anyway. So we didn't make any difference based on their immunization status.
So the bigger kids